Hello, I'm Giuseppe Vercellotti. I'm President and CEO of Rex Implants, and today I have the pleasure of introducing the Piezo implant system to you. We're presenting the Rex Piezo implant system as a minimally invasive solution for narrow ridges. Now, I'm not going to go into the problems with narrow ridges in too much detail. Suffice it to say that when you have a reduced horizontal volume, you also have poor vascular supply. And clearly you have a geometric discrepancy with the size of the implant that you would like to place in the ridge to obtain rehabilitation. So that in turn will lead to dehiscence, or at least a risk of dehiscence, increased risk of marginal bone loss, and possibly peri-implantitis. So typically when we have narrow ridges, the clinical approach is to adopt some kind of decision tree to guide the surgical rehabilitation. This is an example. This is a paper that was published by Fu and Wang in 2011. And as you can see here, they present a few options for the rehabilitation of ridges that are less than 6 millimeters wide. Now, clearly in cases where you have 3.5 millimeters and less, you cannot obtain primary stability with conventional implants. So very invasive procedures such as bone block augmentation are generally called for. Between 3.5 and 4 millimeters, guided bone regeneration tends to be the preferred approach. And you can either do it in two stages, so have GBR first and then go in and place implant, or you can place the implant and contextually have GBR. Now, of course, this is a very invasive procedure, but it's also not very accepted by the patient. But it's certainly an option between 3.5 and 4 millimeters. Now, when you have a ridge that is between 4 and 5 millimeters, you can still go and proceed with a ridge expansion. Now, ridge expansion is ideal in this sense because it creates an intrabony defect that clearly has better chances of success. But still, it's a fairly advanced procedure that does not work for all practitioners. So we at Rex Implants have a different solution. We present an implant that is wedge-shaped and that better conforms to the residual anatomy so that you can go in, rehabilitate an edentulous jaw without having to resort to all of those complex techniques. This image gives you a good idea of how our implant compared to conventional root form implants. And you can see that we have a rectangular cross-section which mimics the anatomy of a crestal bone and allows you to preserve adequate width and thickness of the tissues, both vestibularly and lingually. In this image, you can see that the restorative connection is pretty much the same size, but on the right, to accommodate that connection with a root form implant, you have to compromise the thickness of the tissues. And when you do that, of course, your risk of marginal bone loss and peri-implantitis increases. Now, the implant, as I mentioned, has a wedge shape and a rectangular cross-section, but it's not just that. It has a number of features that really combine features of blades with features of root form implants. You can see that the restorative connection at the top is what people have become used to over the years, and it gives you a much greater versatility in terms of restoration than the posts that you would have with a blade. But we also have a number of surface features that differ from blades and kind of mimic the threads of conventional root form implants. You can see that at the top, we have a machine transcortical region that in and of itself allows to clean the implant if exposed better. It prevents peri-implantitis and prevents, of course, bone loss. But this machine surface also has microgrooves that promote osseointegration within the cortical bone. Below that, we have the portion of the implant that is coming in contact with cancellous bone. And here we have macrogrooves. Macrogrooves promote osseointegration, and this area is also surface treated. And as you go down, you also see that we have an identification port that allows you to assess osseointegration radiographically. And most important, we have a sagittal fin in the middle of the implant, which allows with the insertion of the same and also improves the press fit. This implant, of course, is held in by the interference between the bone and the implant. And so having these features is extremely important to that end. One more thing to mention is that the implant is made of titanium grade 23, which is a better version of titanium grade 5 that has improved biocompatibility and mechanical performance. Now, we have 5 different models of these implants. They all have in common they're wedge-shaped, but the width varies, and we have distinctions in the connection and whether they're bone level and tissue level. So from the left, you can see we have the Rex TL 1.8. It comes in 2 versions. One has the machine transportable section that I was pointing out earlier. This version to the right has surface treatment all the way up to the shoulder. And this is suited for those cases where you have soft tissues and a good closure over the implant, as well as when you can prepare the site only with an extensive technique. The Rex TL 2.9 is clearly thicker and has a better mechanical performance, whereas the Rex BL 2.9 combines the thickness of a Rex TL 2.9 with a bone level platform, so you can have better aesthetic results. And this comes in 2 versions, 4 and 5 millimeters wide. I mentioned the surface treatment a couple of times. All the implants have an RBM surface. It's basically a grid blasted surface with hydroxylapatite. This, of course, increases the surface area and promotes osseointegration. The difference between the implants, as I pointed out, is that the TL18R has a surface treated portion that extends all the way up to the neck, whereas the TL18 has a machine collar. In terms of connections, we have 3 different connections, basically 1 per type of implant. And this is due to the fact that having such a narrow implant, accommodating conventional connections is quite challenging. So the 1.8 clearly doesn't have a lot of intraosseous volume. So it has an external hex with a shorter screw than conventional external hex connections. The screw has a taper so that it doesn't have a problem of screw loosening that you might have encountered with other external hex connections. The Rex TL 2.9 has an internal hex. This is similar to a Zimmer screw vent, and the screw size here is also standard. Whereas the Rex BL 2.9 has a proprietary connection that we have designed specifically for this that combines a Morse taper with a hex for indexing. Now, one of the questions that we get asked most of the time is how these implants compare to conventional implants in terms of mechanical performance. And this graph basically illustrates the similarities between our implants and conventional implants that have a diameter comprised between 3.3 and 3.5 millimeters. So even with our thinnest implants, we can offer the same kind of mechanical performance that conventional implants offer. Now, if you look at the top of the graph, you will see that our Rex TL 2.9 far exceeds the mechanical strength of conventional implants. So even with 2.9 width, you can have extreme mechanical performance. And when you look at bone implant contact, you see that we have very similar results. We have a surface area that is comparable to implants between 3.5 and 4 millimeters wide. So based on these data, you can really think of these implants as an alternative to your roof form implants rather than mini implants and other solutions that don't offer the same kind of mechanical performance. Now, of course, we understand that when you're treating your patients with implants, you want to have a solution that lasts ideally for the patient's life and certainly long-term if properly maintained. And so before we introduced this product, before we obtained clearance, both in Europe and North America for the FDA, we completed a first clinical study. The cases were performed starting in 2009. And we observed the performance of these implants over time. A few things to point out, and we have this paper on our website, so of course I encourage everybody who's interested to go there and read it. But key highlights, the average ridge width for the study was 3.3 millimeters, and survival at 1 year was 98%. At 5+ years, it was 93%. Now we talk about 5+ years because long-term data were collected during COVID, and for that reason, several patients could not assess. But those who were there, even at the longest time intervals, had 93% survival rate. Now, we understand that you might get higher survival with conventional implants in native bone, but when you compare this to narrow ridges, these results are comparable, if not better, than what you would obtain with a bone augmentation procedure. So Rex implants have been validated in the sense to be a valid alternative to those more complex and invasive procedures. One thing to point out is that the marginal bone loss observed with these implants is very limited. At 5+ years, we had less than 1 millimeter. And this is due to the fact that some implants lost exhibited marginal bone loss, but several implants also exhibited net gains in marginal bone. So again, these implants seem to encourage and provide tissue stability in a way that conventional implants cannot achieve in narrow ridges. Now, after that first study, several other publications came out. Some of these are studies that the company was involved in, but many were just publications that our users develop on their own. Because of course, when you introduce something new, people will find new ways to use it. And there are some interesting and creative uses of these implants in the literature now. Also, these publications are available on our website, and we're happy to share them with anybody who might request them. Now, I already mentioned that we have different implant models, but not all of them are equally suited for all cases. So to assist our customers with selecting the best implant for each case, we have created this chart. Basically, you can think that anytime you have at least 3 millimeters, you can place a TL18. Now, the TL18s are best in the front part of the mouth. They are not suitable for single crowns in the posterior. So for single crowns, clearly you would not utilize them in the posterior. Whereas the 2.9 is ideally suited for posterior placement. And the BL implants are best for the aesthetic zone. Now, of course, the difficulty of the cases depends on both the anatomy and the implant size. So we suggest that people who approach the system for the first time place the TL18 first, and ideally when you have 4 millimeters of bone and more. This makes for an easier approach to the system. If you're working in the maxilla, the cortex is typically not as mineralized, and so you can just go in with an expensive technique. If you're working in the mandible, you might also have to subtract some bone because you don't have as much elasticity. And also with the 1/8, of course, as the width of the ridge decreases, the complexity of the surgery increases. So we advise people to just get a feel for the system with 1/8, and then they can move into the 2-9 implants, whether they're tissue level or bone level, ideally in the maxilla first, and then in the mandible. Always keeping in mind that the 2.9 implants will require wider ridges than the 1/8. Now, of course, a note of caution here, each case is different. The difficulty, the actual difficulty varies based on a number of things, including, of course, ridge width, bone mineralization, the number of implants that you're placing, and the surgical technique. So this is just a basic guide. It does not replace the need for a detailed pre-surgical study. Now, To place these implants, you need a few instruments. The first one is piezosurgery. Piezosurgery is necessary to place these implants for a couple of reasons. One is that, of course, by having micro vibrations and a very precise cutting action, it allows you to prepare osteotomies that are non-circular. So, of course, for a rectangular cross-section implant, you need to have a rectangular implant site. So piezosurgery allows you to do that. But then piezosurgery has very important healing characteristics. It has been shown, and there's extensive literature on this topic, that when you use piezosurgery for implant site preparation, you have fewer inflammatory factors. So basically have a more modest inflammatory response. And at the same time, there is an actual activation of bone healing mechanisms with osteoblast differentiation and new bone formation that will lead to a faster osseointegration. So if you think about this in clinical terms, you can think that the use of piezosurgery will lead to less trauma to the bone, which means less of a drop in primary stability due to the removal of bone as part of the inflammatory process. And so as you can see in this graph, when you compare the performance of piezosurgery, performance of drills for the preparation of implant sites, you see that you have less of a drop in primary stability, and over time you actually gain stability and even possibly exceed the level of stability that you had initially. Now, this is, of course, through ISQ values. So piezosurgery is necessary to prepare the site, and because of these healing features, of course, it's important for a crested implant that you minimize bone loss, bone resorption due to the surgical trauma to the fullest extent. So piezosurgery truly is needed for the preparation of a surgical site. And so how do you do that? Well, we have developed a number of inserts in collaboration with Mectron, and we have a series of inserts that can be used in the different steps of a surgical protocol, as I will show you in a few minutes. We also have a number of other instruments. They are consolidated in our surgical tray, so you can have everything at your disposal when you need it. But you have a number of tools, from fit gauges to drivers to removal carriers. And also, we have developed expanders that are specific to our implant. So we have an assortment based on the length of the implant that you're going to place, and we have increasing width to prepare the site in the best possible way. And as you can see here, the profile of these expanders matches that of the implant. So using the appropriately sized expanders allows you to prepare a site that is ideally suited to accommodate one of our Rex implants. One interesting feature about the expanders is that they also have a stop, so you are safe and you're never going to over prepare the site. So if you see that you have, for instance, the mandible, you have a certain height before you reach the inferior alveolar nerve, you can rest assured that the expanders will never over prepare the site. The expanders and the implants are placed with the Rex mallet. The Rex mallet is an electromagnetic mallet. It's an impactor that is less traumatic than a manual mallet. It controls the impulse. The impulse is much shorter so that your patients don't have vertigo as a result of its use. We also have one single handpiece and one attachment to the handpiece that allows you to insert and remove the expanders without having to switch handpieces. Now, once we have reviewed all of the instruments that you need to use for the preparation, I'll show you the protocol. And the protocol is actually much easier than all of the armamentarium might make it sound like. Of course, we mentioned the importance of preoperative planning. Once that has been decided and you have designed your case, you can go in and start your pilot osteotomy. We recommend being at least 1.5 millimeters from adjacent teeth, 3 millimeters from adjacent implant. And once you have defined where your implant is going to go, you can go in with a pilot osteotome, perform your initial osteotomy. And with a pin, you can evaluate the axis of the implant and determine whether it's appropriate or not. You can also easily go in and adjust and correct that initial osteotomy if need be. The next step is to widen the osteotomy, and typically you do that with one of our saws. As you can see, the inserts have depth markings that correspond to the implant, so you always know the appropriate depth of the site based on the implant you have chosen. And if you're using only piezosurgery inserts, so you're not going for an expansive technique, but you're just using a subtractive technique, the next step is typically to use a microfile, as in step 7 here, to remove any bone spicules around the margins of a cut, especially in the corners. If you don't do this, there is a risk that the implant is not going to go in as smoothly, and definitely something that you want to avoid. So to make sure that the site is properly prepared, then you would use a fit gauge. And the fit gauge matches the implant in length and width, and so allows you to see if the site is properly prepared. Now, at this stage, of course, we haven't expanded the site, or we haven't removed bone to accommodate the implant. And so that's what we're going to do in the next step. You can see that we have wedge-shaped files that we have designed specifically for use with these implants. And with them, you can basically do your under preparation for the implant. How much bone you remove, of course, depends on mineralization and elasticity of the bone itself. But when you're performing a subtractive technique, you will have to remove as much bone as the implant body requires, pretty much. So, so you're placing a 1/8, as in this case, you need to remove 1.8 millimeters of bone from the ridge. To make sure that the preparation is correct, we also have additional fit gauges, fit gauge W4 and W4H, which allow you to verify that the site is ready to accommodate the implant. Once that is done, you can go in and place the implant, again, with our mallet. And the implant, at least the 1/8, needs to be placed at the shoulder, or on the bone level needs to be at the shoulder. And once that is done, your surgery is completed. So you can do this in ridges, 3.5, 4 millimeters wide, and you still end up having a millimeter on each side of the implant. Now, I have mentioned that, of course, when you perform a subtractive technique, you're removing a volume of bone that corresponds to the volume of the implant. So, of course, in a narrow ridge, this is not ideal. So over time, the focus has shifted from a subtractive technique to an expansive technique. So the idea here is that you try and really minimize how much bone you remove. And of course, this allows you to have thicker walls on each side of the implant. Of course, because of the precision of piezosurgery, you can also have a differential preparation and ideally save more bone on the buccal side than on the lingual or patellum. So with expansive technique, you pretty much start the same way. So you have your initial osteotomy. You can verify the axis of that implant. And then with the saw, you can go in and perform the initial longitudinal osteotomy. Now, in this case, you depicted our W2 insert, but you can also use other Mectrin inserts that are thinner, and that allows you to preserve even more bone. The next step is where the procedure differs. Instead of going in with the piezosurgery inserts and removing yet more bone, you go in with the expanders. And you do it gradually. As I mentioned, we have a variety of expanders. You will start with the thinnest expand, which is 1.6 millimeters in thickness. And once that is done, you can switch onto the next expander and repeat it until you reach the desired width for the implant that you're placing. Now, if you're working in the maxilla, your procedure might end there. So you just have 2 inserts, 2 expanders if you're placing 1/8, and then you can just tap your implant in. However, when the bone is highly mineralized, so this is optional in the maxilla, but almost always the case in the mandible, you also have to go and perform some subtraction of a bone. So you can see that we have a file that you can use for that. But of course, having used the expanders, you're not removing as much bone as the width of the implant itself. You're just expanding coronally that osteotomy so that the implant can be inserted. And at that point, the insertion is exactly the same. You place your implant. You can, of course, at that point, you remove the transfer, put a cover screw, cover it up, and the procedure is done. So this, of course, is a great technique. Even in ridges as thin as 3.5 millimeters, you can go in and place an implant without having to resort to any complex bone augmentation procedures. Now, let's see this in action. First, I'll show you a subtractive technique, then we see an expansion case as well. Now, in this case, you see that the preparation was performed in the bone and basically matches the size of the implant itself, which is kind of a shame because we're removing more bone than we have to. But also in this case, where you have one case of longstanding edentalism for one tooth, an implant could be placed immediately. And there was also a post-extractive site that was treated with a conventional implant. And you can see in one surgery, this patient received 2 implants with no need to have any kind of advanced procedure. So even in just this one case, reduced crest, the patient could be treated immediately with great results. Most cases will combine the expansion with some degree of subtraction for the under preparation of a cortex. In this case, you see a very thin ridge at the top. We have a ridge that is 2.5 millimeters. In these cases, it's advisable to perform some ridge flattening with an osteoplasty insert to gain suitable width that will also help with the closure of the soft tissues. And in this case, you see the site is in between teeth. So instead of using the W2 insert I showed you earlier, we're using an OT12. The OT12 is longer and straight, so it's ideal for placing implants in between teeth. So the osteotomy is performed with that insert, and then the expanders are placed in the site. You see this is an 11 millimeter expander. And you can see that we have immediately achieved an expansion of the ridge. The next step is to go in with the thicker expander. The first one was 1.6, this is 2.0. And you can see that the expansion is progressing. Now, in this case, they tried, of course, the fit gauge, verified the site. The muscle bone mineralization was such that the expansion was not as much as it was desired. And so they also went in with the file and removed some of the bone. But you can see that the buccal plate here was preserved, and also the parallel plate is pretty thick. So we end up having the soft and hard tissue thicknesses that are ideal for long-term success. Now, in the mandible, I mentioned earlier, you almost always have to combine the expansive and subtractive techniques. You can see also in this case, we have a narrow ridge and very thick cortices. In this case, it's very clear that the subtraction of bone will be required. And again, here, step by step, we have the pilot osteotomy. This is a nice image that shows you how the pilot osteotomy is right at the center of the implant. This is important because there will remain a couple of notches on the sides of the osteotomy. And that's where the sagittal fin of the implant goes, and it guides your implant placement. So you can always make sure that the implant is exactly where you want it. And you can see after the sagittal osteotomy, we have the expanders being placed, subtraction of a bone. You can see the site here is nice expanded, ready to welcome the implant, and the implant has been placed. Implants placed, you can see that in this case, they had a longer osteotomy than in previous cases. It's generally advisable to go as long as you can and as deep as you can, because of course that will allow you to exploit the elasticity of the bone better. And at that point, you just let the clot fill the gap, or you can graft a sponge of collagen, PRF, whatever scaffolding material you would want, but grafting is not necessarily required. In this case, you can see that they measured ISQ values. At this point, the use of Ostel for determining primary stability is not validated in the US, and so is not FDA approved. As a note for those of you who use Ostel over time, you will see that values measured on Rex implants are different from what you would have with conventional implants for two reasons. Of course, the implant is not circular and it's much longer mesiodistally than it is buccolingually. And so you will have different values. And in general, because it is a press fit, you don't have an intimate contact between the threads and the bone, the values will generally be lower, even though that's not always the case. That doesn't mean that the implant is not stable. It's just a feature of these implants. So as long as you can assess primary stability clinically, intrasurgically, you find the implant will heal if given the time to do so. One more thing, if you see that you're not achieving the ideal stability you would like, you can always give it an extra tap with a mallet. But be careful with the 1/8 not to go too deep, because of course at that point, the bone would be expanded by the connection that flares out. So you can see that the ideal implant level is at or right below the implant shoulder. And at this point, you can see that they completed the case, and there was nice tissue healing, and the width of the ridge when the procedure was completed actually quite impressive. You can see radiographically the implant is doing well. You have good results. Again, one single surgery, no advanced bone augmentation procedures. I'm going to show you also a couple of cases with Rex BL. Now, Rex BL generally is more advanced for a couple of reasons. One is that the insertion of these implants is a bit more challenging because of the width, but also because the implant does not have a single sagittal fin. It has two fins that, of course, stabilizes when it's in the bone, but it has more interference going down. And then, of course, it's more challenging because you will typically use these implants for cases that have high aesthetic demand. So I generally don't recommend starting with the bone levels. They're great implants, but something that is best introduced once you have had some experience and you're familiar with our system. This is one of the very first cases that were completed with a Rex bone level. This is the central incisor, as you can see. The case was performed in 2013, and 10 years later, you can see that even with a patient that has not the best compliance, you have very stable tissue around the implant. So you have, I'd say, no marginal bone loss. In this case, the patient has a good long-term solution and in an aesthetic area. This is another case for a Rex bone level. In this case, we're looking at a canine. What you can appreciate here is that the procedure is the same that I showed earlier. So implant, pilot, expansion, and placement. What differs with the bone level is that you can place it at bone level or below bone level up to 2 millimeters, and we have different carriers, and we have a number of restorative parts that allow you to restore it the best possible way, because of course it's designed to go into the aesthetic zone. With a bone level, it is fairly common to find higher ISQ values than with the other implants, because being placed at bone level, actually under bone level, you have the ridge that you have expanded will close over the implant, giving you this very nice eye Ostel readings. And as you can see, the implant here was slightly bone level, and they could restore the case based on its aesthetic demands. Now, one thing that we are asked very often is, how do you obtain the best results when you're working on ridges that are so thin? Well, that is typically by combining the surgical technique with a digital workflow and guided surgery. So at this time, we have digital libraries for exocad, dental wings, and 3Shape. They're available on our website, and this allows you to integrate our implants into your digital workflow. If you are primarily concerned with digital planning, then You can rest assured that we are in a variety of software packages. Again, you can find all of the details on our website. And we also have design surgical guides. At this point, we can either work with you or recommend companies that assist with guided surgery and can produce the guides for you. And so this allows you to really incorporate our implants into your surgical practice exactly the way you work with any other implant. One last thing, of course, this presentation was pretty brief. It's just meant to give you an overview of the system, explain the differences between implants, and show you the protocol, but it's not intended to be all-inclusive and exhaustive. For that, we offer training courses. Training courses are something that we highly recommend if you want to get the most out of this system. And once you become a customer, you can attend as many as you would like at no charge. It's part of our commitment to making sure that you have all of the tools that you need to really incorporate Rex in your practice and get the most out of this surgical solution. And with this, I thank you very much for your attention, and I hope you will be in touch, and we will be happy to answer any questions that you have on the system. Thank you.